Hi, and welcome back to Talking About the Taboo. You are listening to yours truly, Natalie Malloy. This podcast was made for individuals who have a curious mind, who want to know more about sex and relationships, and to really talk about the taboo. Today, we have a guest on the show by the name of Dr. Corey Babb. Dr. Corey Babb is a Tulsa, Oklahoma native and is dedicated to improving female sexual health through education, advocacy, and compassionate care. As a board certified gynecologist, he is also a fellow of the International Society for the Study of Women's Sexual Health and a certified menopause society practitioner. Trained by Dr. Peter Pasek, Dr. Babb specializes in a Botox treatment for vaginismus, which has success rates of over 90%. He is also a co-author on an important study about vaginismus published in Sexual Medicine. Dr. Babb serves on the board of the International Society for the Study of Women's Sexual Health, reviews for medical journals, and gives lectures around the world. At Haven Center, his gynecologist practice, he welcomes patients from all over and is passionate about treating health issues that are often overlooked and misunderstood. This episode is an educational one. Of course, always we're going to be entertaining, but it's educational. If you've had those questions where you go to the gynecologist and you're too scared to get answered, today is where this is the episode where it's going to be answered. Today, your questions are going to be answered. It is communicate time. It is that hour where you sit down in your car or in your kitchen while doing dishes and absorb like a sponge, because it is not every day that you get to hear the raw information about hormone therapy and the benefits of weed. And we're going to sit down and talk about his practice and visits to the gynecologist office, as well as breaking those myths when we go down into the segment called Taboo Talks. So stay tuned. You're going to love it. I love you all. XOXO. Communicate. Locked up, they won't let me out. All right, let's face it. In the right hands, love holds no restraints. The sex toy of the week is fucking handcuffs. If you're not implementing handcuffs in the bedroom, I'm not quite sure you've had the experience of the fucking amazeballness that it really truly is. Especially these cuffs, okay? The cuffs versus handcuffs, right? There's those cuffs that are more like the police arrest you with, that hurt your, wrists, and it just doesn't feel comfortable. Many people really do like those and like the pain around their wrists. But if you're anything like me in the bedroom, if I am uncomfortable while I'm having sex in any way, shape, or form, and the pain doesn't feel right, I am going to focus on the pain rather than the pleasure. And with pain, there is pleasure, but the right kind. These cuffs have I didn't put them on tight enough. That's why they come off so tightly. A fluffy inside, which is why they are so comfortable. The color was picked out by my boyfriend. He loves them, and I recommend handcuffs in any way, shape, or form. Let loose and let the restraints do the rest. Hello. As you guys can see, I have another person with me today by the name of Dr. Corey Babb. Hello. How are you?
Hello. Just fine. How are you doing?
Good. I want to thank you so much for coming on my show, taking the time out of your busy life, and to talk about sexual health.
Yeah, it's my pleasure.
And I really appreciate what you do advocating for women's sexual health, just sexual health in general. As you guys have heard from the introduction that I had read for you guys, you know that he is a very prestigious gentleman. He is involved in many different establishments. And I think that what he does, it's so important and definitely a part of my mission as well. So I want to do a little icebreaker with you to make you feel a
Totally.
little bit more comfy in here.
Yeah.
So I am going to ask you a question. So if you could give your younger self one piece of advice about sexual health, what would it be?
Oh man. So yeah. So I grew up purity culture, like
Mm.
big time purity culture, And
Okay.
that is something that, even though I tried to kind of rebel against it in my own way, still very much influenced my kind of thought about sexuality, kind of the inherent, is this wrong? Things along those lines for, I mean, most of my life, honestly, up until kind of fairly recently, still dealing with a lot of that stuff. So my advice to my younger self would say, hey, there are ways to, a lot of that it's not, don't take it to be gospel.
Yeah.
And, really kind of stay true to your guns with what you feel.
Okay, that's actually super interesting to hear. So then you came from that purity culture. Then how did you get from that to where you are now with such an open mindset to this?
Well, I think most of us that end up doing things kind of in this realm, it's a little bit unique in that we all tend to have struggled with our own personal demons with it. I know a lot of, for instance, pelvic floor physical therapists that have pelvic floor dysfunctions.
Yeah.
A lot of people that go into sex counseling have done that because there's been something sexually speaking in their past that's been traumatic to them, or that they felt to kind of get through that. So I think that really kind of overshadowed my journey with all of this, and saying, hey, if I felt broken, for a
Mhm.
long time with it, like maybe there are ways I can go about and keep others from dealing with that, or help them get through that process too.
Yeah, it's like we're all a sense of a peer. Anything that we've been through, we feel as if we've
Mhm.
kind of gained a wiseness to it
Right.
and can add on to it. And then you're also educated as well on top of that. So talk a little bit about what you are involved in and kind of how you started this.
Yeah. So my background, I'm a gynecologist by training. So obviously went through medical school, then did OBGYN residency. And really with that, we don't get hardly any training in terms of sexual concerns, menopause, hormone therapy. Really, that is very much focused on, hey, this is a pregnant patient. How do you take care of them? And after they're done being pregnant, how do you take out their uterus? Pretty much. And
It's
here, let's talk about
basic.
birth control too.
Right.
And so after I got out of residency, I was in private practice, and I kept having these patients come in that would ask me these questions that I didn't know the answer to. And I
Mm,
think, like most physicians, we don't like not knowing the answer to things. And
okay.
so I found, kind of in doing my own research, the International Society for the Study of Women's Sexual Health. Or ISWISH is what kind of the acronym for that is. And that's probably it is the world's like biggest female sexual medicine specialty society. And so I
Hmm.
started off going to those meetings, and have since kind of worked my way through the ranks of that, becoming a fellow of that society, so doing very specialized training in that. And I'm on the board of directors for that society too now. So it's been a multi-year process, but that's kind of been the trip that took me to where I am today.
And so within all of those things that you are involved in, what has been a struggle as a gynecologist through and through all of that?
Yeah. I mean, I think kind of the one of the biggest things is dealing with lack of education and fellow providers.
Yeah.
I remember one time trying to go, when I was looking for a job before I started kind of my own practice, um, you know, talking to people about referrals. And this one fellow OBGYN, he's like, well, I don't have any patients with sexual issues.
Hmm.
And I was like, 40 statistically speaking, 40% of people that identify as women have some sort of sexual concern. So you do, you're just not
Yes.
asking the question,
Mhm.
you know.
Mhm.
And so I think that's been kind of changing the public opinion about things, and realizing, hey, this is real stuff. This is stuff that we can do things about. And for a lot of patients that suffer in silence, kind of bringing them out of that shell and saying, hey, you don't have to feel like that, there are things we
Yeah.
can do to help.
I really like that. Diving back into not asking the right questions. That is why I brought you on. You in your TikTok, which we'll talk about too later in our sneaky links segment, is just so open-minded, and it gives more of an introspect into the idea that there's so many things that are not talked about in depth at the gynecologist.
Right.
And so you specialize in, many different things: vaginismus,
Mhm.
hormone deficiency, vaginismus under sexual dysfunction. I want to start with going over the hormone deficiency. These things are just so not talked about,
Right.
especially like weight gain, mood, testosterone therapy. So go at it. Tell me what I need to
Yeah.
know.
So I think the biggest thing right now, so many people think hormones are, they're either dangerous. They may have heard, oh my gosh, if you're on hormones, you're going to get, cancer, things like that. Or they have this idea that, if you're on, for instance, testosterone, that's going to be something you're going to end up looking like a bodybuilder, and
Yeah.
there's nothing further from the truth. So when you look at things from a purely scientific standpoint, so for people that have ovaries, their ovaries actually make 4 to 10 times more testosterone on a daily basis than they make estrogens. And we normally think about like estrogen as a female hormone and testosterone as a male hormone. And, if you put a 60-year-old dude next to a 60-year-old lady, he actually makes more estrogen than she does at that time. So, hormones are hormones. They don't care what you are, what your pronouns are, like anything like that. They are just secreted and tell your body kind of what to do. Yeah. Now, we do know that when we turn 30, gonadal hormone production, so production from the ovaries or the testicles, starts to go down little by little every year. And when you hit 40, it really ramps up. And so what we start to see is patients coming in and they're maybe in their mid 30s. They're like, I just don't feel the best. Maybe I used to have more energy, or now I'm having some more anxiety, or things seem to bother me more. And then as the years go past, they're like, well, hey, now, I got these mood swings. I can't remember. I walk into a room. I don't know what I'm doing there. I got this weight gain. It's all in my midsection. Nothing's changing. Like I like my partner, but I don't have any sexual desire to do anything with them. Or if I do, it doesn't feel the same way it used to, stuff like that.
Yeah.
And these are all due
real
to
things.
are all due to hormonal fluctuations. And for people who have a menstrual cycle, which typically the hormones in the menstrual cycle kind of go up and down and up and down. So it's kind of gentle rise and fall. What we see as time goes on is that the peak is not so high, but the valley really goes down. And when you cross that certain threshold on the bottom, that's really when a lot of these symptoms start to manifest. And so part of what we do with hormonal therapy is finding what the symptoms are and then adjusting things as they need to be.
How does birth control affect that? Because I've been on birth control since I was 14, amongst my other peers as well. I know.
Yeah.
And it's the same birth control. I switched it once, and many of my peers and vice versa, people who watch this podcast come to me and they are struggling because they either want to get on birth control because they think it's going to fix it, but then they're on birth control and it's not fixing it. And it's a mess. So explain birth control and hormones.
Yeah. So birth control is basically, the thought behind a birth control is you're going to use either a pill or a patch or an intravaginal ring or whatever you're going to do. And there are two generally types of hormones in there. There's a synthetic estrogen called ethinyl estradiol, and there's a synthetic progesterone in there, and it can be a different type. And what those basically do, when you take the pill or you put the patch on, it makes your ovaries say, you know what, I don't have to do anything. So actual ovarian hormone production shuts off. You become basically wholly dependent on what the birth control is giving you. And this is why for a lot of people, when they first start a birth control, like the first 3 months, they're like, I felt terrible. I don't know I'm getting all this weight. I'm bloating. My skin's breaking out. It's because you're having this tug of war between what your own hormones are doing and what the birth control is. Now, fast forward, if you've been on it for a long time, your ovaries, if we were to check your hormone levels, they would look like you're menopausal because they're just not doing anything.
Really?
Yeah. And for some people, they have a genetic issue with chromosome 17. And that type of estrogen, that ethinyl estradiol, can cause an almost permanent elevation in this very specific peptide that your liver produces that can permanently lower your testosterone levels. So it's something that you always want to be careful if that's been going for a long time, things that you should have been told in the beginning, but a lot of healthcare providers, unfortunately, don't know that.
And at the gynecologist, myself and my peers, we're not being told these important concepts. They're just like, who are you sleeping with? Okay,
Right.
Cool. And are you using protection? Okay, cool. You're on birth control. Okay, cool. We're not talking about the real questions. We're not talking about, are you enjoying sex? We're not talking about, how is your sexual health? How have you been, how's your discharge? We're not talking about, you've been on birth control since you were 14. Are you thinking of getting off of it?
Right.
Those are the questions that are not being, asked, and nor are us as, a client knowing to ask these questions.
Sure.
it's just such a struggle. And, with birth control in general and hormones, everyone's just so confused. And there is I don't know if this is a myth, but a concern where if you get off birth control, the whole body is going to go haywire. And then one person even said, I feel like I get off birth control, I'm not going to like my partner anymore. And so how would you,
Hmm.
respond to someone who
Interesting.
says that? Yeah, I know.
Yeah. So there is some truth to that because you've taken away. So let's say you've been on birth control for 20 years.
Mm-hmm.
Okay, so your ovaries have basically been like, we're not doing anything. We're on vacation. We've gone to Bermuda, whatever. So now you take away the birth control. The ovaries like, oh crap, we got to do something because your brain is sending out these massive signals, being like, you got to do it. I need you to work right now. And so the ovaries kind of go into overdrive, and now you get this huge hormonal surge. And you're right, people they're like, I feel crazy. What's going on? I got breast tenderness. I'm getting migraines. That will steady off after a few 6 to 12 weeks or so. It takes about that long for you to kind of fully get back to what your own body is doing. Now, is it going to change how you feel about people? I mean, that would be an individual thing. That's not it's not kind of in the like caution going back on, going off birth control to make you change how you feel about your partner. But we do know that both estrogens and testosterone function very similarly to serotonin and dopamine, respectively, in your brain. Okay. And so there's connections with neurotransmitters there too. So yeah, maybe you feel like you're like, I'm not as calm as I was, or I feel like I'm kind of scatterbrained in that beginning, when you go off of them. But that should, even out as well.
So for individuals who have been on birth control, who are thinking about birth control, what would you say and or recommend to them?
So obviously, there is a very positive reason to be on some form of birth control. When it first came out, now you have women who are able to take this and are be able to have sex and not worry about getting pregnant, right? Like that's a very positive thing from a contraception side. Yeah. Also, if you have endometriosis, really heavy periods, PCOS, there are other reasons to use them. Yeah. I would just say if you're thinking about going on them, to really kind of look at the pros and cons, and there are a bunch of different types.
Yeah.
And those can work differently depending on what your actual needs are. One type may work better for you than another.
Yeah. So the non-hormonal birth control, when you went to this convention, did they give any recommendations for, I'm not quite sure what happens here, but for products or anything that's like a non-hormonal birth control that's in research right now?
So the two main kind of newest, the newest non-hormonal birth control is a contraceptive gel called Phexxi. It's a type of, it's a lactic acid, I think, or citric acid derivative. And basically it comes in a little syringe, and like 30 minutes to an hour before sexual activity, you insert it into the vagina, and it basically acts like a spermicide. That's kind of the thought behind it. And they have done some studies that, maybe it can help for bacterial vaginosis or yeast infections or things like that.
Like a boric acid.
Exactly. Because it's making the vagina more acidic, which is the same thing that boric acid does. The other thing that a lot of people think about, if they're not talking about like condoms or diaphragms or those kind of barrier methods, is a copper intrauterine device. It goes by the trade name of Paragard. And Paragards last for 10 years, sometimes more. And that copper is toxic to sperm. So it acts, basically, it just sits there and kind of acts like a little machine gun, sperm combined. Yeah. And so those are the two kind of main non-hormonal birth controls that are kind of really more medically available, I should say, that aren't kind of more of an over-the-counter type thing.
For that one birth control, the first one that you mentioned with the syringe, I feel as if that really does take away the fun and spontaneity with sex, because it just like, I feel like whoever did make that, no disrespect, really didn't put the mindset of spontaneity in that fun and sex in mind, because I'm not going to think about having sex 30 minutes before having sex. I'm just going to get horny and have sex, you know? So I feel like that would be like a difficult one for individuals to get on board with.
And I think that, maybe their thought is like, and like, oh, you could use this as part of foreplay or something like that. But no one's gonna be like, all
Yeah.
right, honey, draw up our syringe and here we
Yeah.
go. So I agree. As much as I hate to say it, a lot of times the people that are thinking of these, you are absolutely correct, are not thinking about anything other than the, end result of, in that case, preventing unintended pregnancies.
Yes. And speaking of unintended pregnancies, and we're on that topic, what is your take as a gynecologist on vasectomies? This is a
Yeah.
humongous topic, so I want your take on it.
Sure. So the official standpoint from the American College of Obstetricians and Gynecologists is that if you're looking at permanent, like irreversible sterilization, vasectomies are the number one preferred thing. So especially versus getting your tubes tied. Vasectomies is an outpatient procedure. You don't have to go under anesthesia. The recovery is a lot quicker.
Mhm.
It is much more like a much nicer thing to do than to take a person and put them under general anesthesia, open their belly up, go in and find the tubes
Mhm.
and do things like that. So yeah, so I'm very much pro vasectomy.
That's amazing to hear too, because a lot of individuals have like this back and forth mindset of, I'm gonna tell my boyfriend I want my boyfriend to get a vasectomy, but like I don't want to take birth control anymore. Like, there's such a like a back and forthness.
Sure,
So a lot of people are back and forth between, how do I ask my boyfriend to get a vasectomy? Is that the right thing? How do I even bring that up? And also for my male viewers, they could consider it. They're very pro vasectomy, but they're scared. They're scared.
sure,
What
yeah.
is what is that healing process in a picture like?
Sure. So, I mean, basically, so the surgery itself is really straightforward. I mean, there are two main types of vasectomies, and I am not a urologist; I do not do them. But basically, the most common type is you would make a small incision, literally like this big,
Mhm.
in the scrotum, and after you have numbed up the entire area, so you get this kind of big, it's called a nerve block. So they're given an injection of medication, and it numbs the penis, the scrotum, like all the surrounding areas. And then basically you go in and you find the vas deferens, that's the vasectomy part of it. And
Mhm.
so that you find it and you basically tie it off, take a little piece out of it out. Do the same thing with the other side, and then maybe you put a stitch in the scrotum, or maybe you just put some kind of surgical super glue there, and they go home with a ice pack basically in a jock strap.
Mm.
And recovery time for it is pretty. I mean, that day and the next couple of days are kind of sore, but after that,
Yeah.
it gets much better and better and better.
Yeah.
And then the big thing with it, there is either, depending on what your urologist says, they either want you to have X number of ejaculations or to wait for a certain time and then come in for a semen analysis to check to make sure there aren't any sperm in that semen sample to make sure that it's done its job.
How young is too young for a vasectomy in your eyes?
Oh, that's a great question.
Mhm.
So, I mean, I am not a person to say, well, you are too young for that.
Yeah.
Um, I've had patients back when, doing kind of tubal ligations. I mean, we did tubals on patients who were in their early 20s. If there were things that they were like, hey, I don't want to have children. Some of them it was, I have a genetic issue I'm worried about. Some of them was, hey, I want to adopt. I don't want to have any kids of my own. Like
Yep.
when I was in training, they were like, oh, you have to worry about post tubal regret. These patients would come
Mm.
back 10 years later, and they gave this horrible scenario. And I hate this. They were like, imagine all of your children died in a car wreck and you were the only person left. And then you got married again. Wouldn't you want to be able to have kids
Oh
again?
my.
And
Yeah.
it's like, that's a terrible thing to like tell someone, like,
Yeah.
oh, you want to well, imagine if all your kids die,
Oh my
you know?
gosh. Yeah, that's horrific. Like, interesting.
So I don't think, some states, especially if they're using state run insurance, like I'm in
Yeah.
Oklahoma, so it's Sooner Care here. Typically you have to be of a certain age before your insurance will pay for it,
Okay. Yep.
with certain exceptions. But usually that's around 21. I mean, for most people, you
Hmm.
know.
That's actually really important to hear from a gynecologist, is that you aren't kind of telling people, no, don't do this, like trying to make a decision for them.
Right.
Very more of a a client first type mindset. Kind of moving forward to we could protect ourselves all we want, but if we're not having good sex, we're struggling. And not having good sex, unfortunately, can be because of sexual dysfunction. It is humongous for a lot of people. I know you specialize in vaginismus, so I kind of want to start there. So tell me what I need to know about vaginismus.
Well, so for people that don't know, vaginismus basically is an uncontrolled spasming of the muscles at the entrance to the vagina. And it is typically thought of as kind of a almost a protective response. You know, if and I tell patients, you know, if I come up to you and I say, I'm going to hit you and act like I'm going to punch you, unless you're like an MMA fighter or something, your initial tendency is to kind of tense up. Well, basically, that's what those muscles are doing. They like see something coming out the vagina. It could be a penis, it could be a tampon, a speculum, a Q-tip. Like, it doesn't matter what it is. And those muscles spasm shut, and so it becomes very difficult for anything to get into or to get through. And obviously, if you are trying to have penetrative sexual activity, you know, that does not feel good.
Yeah.
And the other thing, when those muscles are really tight, they actually inhibit blood flow to the tissue. So sometimes patients actually, if they try and have sex kind of, you know, push through it, they'll tear, and then they can have bleeding.
Wow.
I mean, it just creates this whole vicious cycle.
Yeah.
And so we know that statistically, vaginismus tends to affect people that come from either a very religious upbringing, a very strict upbringing, or for people that may have had some conceptions about penetrative activity, no matter what it may be, that it's going to be really painful. You know, maybe their great aunt Bertha told them sex is going to be terrible until you get married. You know, it's going to hurt like nothing else. And even if they're like, okay, well, I thought this for 20 years. Now I said I do. And you know, their brain is thinking, you know, this is going to hurt. Right. Yeah. So that's kind of what it is. The way that we treat it. So one of my mentors, Peter Pasek, is kind of or when he was in practice, was kind of considered the godfather for using Botox injections for vaginismus. So
that's very interesting.
Yeah. So Botox, you know, is a muscle relaxant. So it's a paralytic. And so we actually, under anesthesia, inject it into those muscles so they can't spasm shut. And it doesn't like decrease, you know, you're still able to go to the bathroom. It doesn't like make everything just go boom, you know, just be like loosey-goosey or whatever. But it's something that, you know, using that plus using vaginal dilators, maybe pelvic floor physical therapy, some psychotherapy, different things like that. We have around at our office between a 95 and 97% success rate in getting patients to be able to have painless penetrative sexual activity.
Is this procedure something covered by insurance, or is it just under?
Most of the time, no. And that
crazy.
So vaginismus is, if you look at insurance codes, is classified as a mental health disorder.
What?
Yep.
This is the issue. This is I could go on. My gosh, healthcare. I live in New York, Buffalo, New York. I can't. What?
Yeah. So
oh my
there
God.
is a GYN code that's called, it's like says physiologic vaginismus not due to otherwise blah, blah, you know, like kind of all the things. But the true, and this is the true of most of the sexual dysfunction codes are all mental health codes, which is horrible.
Wow.
You know, I mean, obviously the brain, yes, that's the largest sexual organ we have, but you know, you can have low sexual desire because it hurts every time you have sex, right?
Yes.
You know, I don't want to slam my hand in a car door. I know that's going to hurt.
Right.
So if I knew sex was going to be painful, why would I want to have it?
Mind blown. Wow.
So, yeah.
That's so hard too, to have a client come in and express these concerns, whether it be vaginismus or whatever they're coming in with, endometriosis and just things in general, and to be kind of turned down essentially by insurance, making them feel like they are crazy, literally. Like it's a psychological issue. Wow. Okay. So with vaginismus, obviously there's some struggle and everyone talks about, oh, you have a tight pussy. How would you kind of respond to that? And someone says, oh, I don't want my tight pussy to go away. Like, I know that's like pretty like vulgar, but it's true.
No, it's true. I mean, that's a concern that patients have with it 100%. And this is the thing, like there's a difference between having muscle tone that is there and that is healthy and having what's called spasticity, and that's really what we see with vaginismus. It is not a healthy response to that. Like the vagina, those muscles at the entrance to it should not prohibit anything going in,
Yes.
And you think about it, if you're trying to put a tampon in and you're like, I can't put this tampon in, would you say, oh, that, I'm really happy I've got that degree of tightness, I can't even fit a tampon in? Like most, that would be something that would be a little bit unusual for people to say that's a point of pride. But doing the treatment for it is not going to, you're not going to go from, let's say, someone who, heaven forbid, had massive pelvic trauma and lost all muscle tone in their, pelvis and their vagina to where, it's something that is very, almost like no form to it at all by doing treatment for vaginismus. You're going to make it so that, a penis or a tampon or a speculum or whatever can insert there and it's not painful. And that's the other side of it too.
The painful tampon insertion. I have a friend of mine and currently myself. I do not use tampons. I cannot insert tampons. During sex, I don't feel as if I tense up because of vaginismus. But now that you brought up tampons, I didn't think about that. I don't wear them because I cannot get them. I have to do some sensate focus in order to even get it halfway, and I use the teeny tiny one. So that's interesting. So does that mean this automatically, because I can't get a tampon and I have vaginismus and I have to fix it, or?
No, not at all. And this is something that we see, with vaginismus specifically. So you can have a generalized condition to where it is anything going in the vagina, or it can be very specific. Like we have patients that come in, they're like, I can't have sex. Like my partner, we try and have sex, his penis hits a brick wall, basically. But she can tolerate a large speculum in the exam, So like it's that's where it kind of gets up here of what that protective, almost like, I don't want to say a panic response because that's not appropriate what it is, but that kind of heightened anxiety about something going in. It can be very focused on one specific thing, like a tampon. Now, the other thing that can go on is that you can actually have pain with insertion that's not due to vaginismus at all. The tissue at the entrance of the vagina is called the vestibule. And there are a lot of things that can cause issues there that it makes it really uncomfortable for something to pass through and touch that tissue. So
that's actually really intriguing to hear. Okay, so for individuals, it's kind of like more of like a comorbidity. Like you can have this with this, then you would have. Okay, interesting. Good to know. What about something else you talk about? Orgasm disorder. This is very intriguing to me, and I don't know much about it, and I definitely know my viewers want to hear more about it.
Yeah, so we basically, when we talk about orgasmic disorder, there's kind of three main types, if you will. So there's, for female patients, we have what's called female orgasmic disorder. There's also male orgasmic disorder. Basically, all that is saying is, do you have a penis or do you have, a vagina and vulva and whatever your parts are? The gist of that is that with stimulation, either by yourself or with a partner, you have a difficult time achieving orgasm. Now, maybe you can, like with yourself, we have patients who are like, hey, I can orgasm just fine with it if I'm using a vibrator, but if I'm trying to have penetrative sex, it's not going to happen. Like that's not going to do it. And that's actually really normal. That's not a disorder at all. 75% of people with vulvas have to have clitoral stimulation in order to orgasm. And, if you're just trying to get it from penetration alone, it's kind of like, forgive me for being, kind of vulgar, but trying to just kind of stimulate a penis by rubbing the shaft.
Right.
Kind of, what's going on. And, a lot of guys, that's not going to really do. Yeah. So that's the kind of the generalized orgasmic disorder. The second thing is what's basically called an orgasm or dysorgasmia, or the newer term, you were getting into what's called post-orgasmic illness syndrome. So when you orgasm, there's pain, you get like a headache, you may feel like you've come down with the flu. It doesn't feel good, basically. You can get there, no problem, but it's the after effects are not enjoyable. And then the third type is what's called PDOD, or pleasure dissociative orgasmic disorder. And that's someone who has an orgasm and they know they're having one, like they feel their muscles contract, or if they have a penis, they see, ejaculation occurs, but there's no pleasure with it at all. It's just
Hmm.
like, oh, I ejaculated. Cool.
Wow.
So
Yeah.
those are three main types.
This may be a breaking the myth here, but is there a disorder for individuals who cannot stop coming, like
Uh,
females?
yeah, so you're kind of getting into with that. So let me kind of ask a kind of a rephrase question for that. So
Mm-hmm.
there is a condition called persistent genital arousal disorder, or PGAD. These patients feel unwanted, undesired sexual arousal that is bothersome to them. And it can happen like every minute. They can have, it feels like, their genitalia is getting engorged. If they have a penis, they're getting an erection.
Yeah.
And those patients will often orgasm or bring themselves to orgasm as a means to try and relieve that sensation.
Okay.
So that for a lot of people, I think there's kind of a little bit of confusion because these people are like, yeah, orgasm like 25 times a day. It's not because they are just going and going and going. It's
Right.
because they're like, oh my gosh, it hurts unless I do that.
Okay.
Yeah. Now you can have certain types of brain trauma, like if you had a certain like a brain tumor, things that's triggering some of the kind of orgasmic response in your brain and down your spinal cord to where you would have more just kind of spontaneous orgasms.
Yes.
But that's even more rare than the persistent genital arousal disorder, which is fairly rare on its own.
That's really because I know in the movies they kind of make fun of it a little bit.
Right.
I've seen it and people are like laughing at it, but in retrospect, that is something that you just explained is real. Is so real. And
Yeah.
it's not really, it's like probably really aggravating for them, and I know people use humor to cope with things, but that's something that I just was curious about. When it
Well, yeah, and
comes
with that, like the PGAD has a 40% suicidality with it.
Oh my gosh. Yep. You know what, and
Because
that is so devastating.
people don't take them seriously. Imagine if you're like, well, hey, you go to the doctor, you're like, I feel like I'm aroused all the time. I ride in a bumpy car, I hear loud music, I get aroused, it hurts. I just feel like I'm getting aroused all the time. They're like, well, I wish I was aroused all the time. Like they
Yeah.
get gaslit and stuff. So it's very real, and it kills a lot of people that have it.
And is there anything to subside the symptoms of that?
Yeah, so we actually do have this came out a few years ago. So I was actually at the very first conference where this was really identified as a big kind of special, interest group thing. And so we
Mm-hmm.
have a protocol of how we treat it. We've broken down PGAD into 5 different regions. And so we kind of go region 1, 2, 3, 4, 5 as we're trying to figure out what the cause is. So yes, there are ways to treat it, but you have to find someone that A, knows what this thing is,
Mm-hmm.
and B, how to do that. This is where I have a lot of my patients from across the world that we have. A guy today from Iraq sent me a message being like, I have
Well,
this. There's nothing I can do. Please help. And it's like,
mm-hmm.
how am I supposed to do something in Iraq?
From
Yeah.
that far. So we could have all of these, these dysfunctions and whatever classification it is. When you went to this convention, what
Mm-hmm.
was a form of a drug that they had mentioned that will assist with these orgasmic disorders or vaginismus?
Yeah, sure. So, some of the new stuff is for orgasmic disorders, especially is focusing on kind of cannabinoids. So, different
Yeah,
things we get from, cannabis on the different kind of
amazing.
breakdowns, from whether it is actually more of a THC, if it's, kind of a cannabinol, a cannabidiol, the actually different substrates there. And there's actually a really good bit of data on
Hmm.
cannabinoids and they're similar substrates that are very helpful in helping patients achieve orgasm. We're kind of focusing on the more kind of female, in the case of female patients, female orgasmic disorders.
Weed and CBD changes your sex life. I get it. You're like, excuse me, I don't smoke. Listen here. You don't need to. Changes in sexual medicine are happening. They are explained in this episode. So today I have a serum I wanted to promote. This serum was from a dispensary in Florida. It is the Awaken Arousal Oil with CBD. So it's not necessarily THC. As discussed in this episode, we will get to it. CBD and THC involves enhancements in orgasms and sexual arousal. Sometimes there's distinctions between the two, but this is a little dopper. You take it out, you squeeze it, you put a couple drops externally on your clitoris and you let it rub it in. You start maybe using the vibrator and you let that fucking shit do its thing.
And
Yeah.
with the marijuana, it can sometimes be, opposite in terms of orgasmic stuff, but depending on the strand, whether it's like a sativa or an indica or whatever it may be, those have different kind of effects too.
Yeah.
And that it's a burgeoning area of research, honestly. I mean, I hope that there's still research on it. But
we'll see. I think over
yeah,
time, hopefully, as we move more into this era of acceptance, legalizing things, we can see more of weed in sexual health,
sure.
cannabis, CBD, anything like that implemented in sexual health. You can go to a dispensary as well and ask them specifically, hey, what sexual health products do you have?
Yep.
And it does exist. It's just so taboo that
Right.
they don't know how to answer it. So I thank you so much for speaking on that.
Sure.
Like two taboo topics at once. So while watching your TikTok, I kind of saw that you consider yourself, well, others may consider yourself more of an unorthodox gynecologist because because of your office and your visits. So you are at the Haven House in Oklahoma.
Haven
Talk
Center.
about
Yep.
Haven Center, Haven
Yep.
Center. Talk more about that new era of gynecology visits.
Yeah, so what we really try to do with Haven Center is make it something that is completely unlike a doctor's office visit at all. So we're in kind of it looks like a little house, basically. And we really only have one patient there at a time. Patients don't wait in a waiting room. That we have a parlor basically that they wait in. That's private because a lot of the patients. So we specialize in sexual issues, menopause and hormone therapy, and then what are called vulvovaginal disorders. So like chronic, vaginal infections, lichen sclerosis, vaginal itching, things like that. That are all very sensitive topics. And a lot of our thought was if a lot of people are coming in, they don't want to sit there and like be looking at other people and be like, hey, what are you here for?
Right. Yep.
That's so true. We also made it so that our office visits, our new patients are an hour in length. Our new visits are, and then our established patient visits are 30 minutes in length. And we do almost all of our visit in kind of a consultation room. There's not like a exam table or anything like that. It looks like a living room. Yeah, it's got like a couch. It's got chairs, things along those lines, and really just trying to make this very much person-centered care where the patient, they don't even feel like a patient. They feel like, hey, we're just having an honest conversation about what's going on. And then if we need to do an exam, we use an examination chair. We don't have like a table that people have to lay down on and stuff like that. We have spa robes. We have swaddling blanket cloths on it, stuff like that. So no one's ever going to be like, you know what I want to do? Go to the gynecologist today. Like I fully understand that. But
it's a spa day.
Yeah, exactly. You want to try. We have tried to make as an uncomfortable situation as comfortable as possible.
Right. And I really love that. And I'll definitely share a video of when you were walking around the office. And I just really appreciate that. And that's just something that does not exist here. I hate going to the gynecologist. I hate putting my feet in the stirrups. I do not like what I call the duck. Okay. Yeah, it just doesn't feel good. I don't like it. I don't like the nurse coming in asking me the same random questions over and over and over and over again. And it's like, okay, cool, bye. And then gynecologist comes in rough and, well, not rough, but like it feels rough. It feels so quick. And because if you get on to the next person, so watching that video brought like comfort for individuals, at least in your area or individuals that are able to visit you.
Yep.
Getting into the hard topics of being a gynecologist. So I read some of your comments and some of them aren't very understanding. And one of those comments says, well, essentially, I'll ask it in a question is, how would you respond to an individual who is skeptical about going to a male gynecologist versus
Sure.
a female gynecologist?
And I think this is one of the most common things that we, see. Like, I do not have the experiential, history that a, person who has the parts and has been through that stuff, has. And I 100% recognize that. I think for me, what that means is that, hey, if you tell me this part hurts, this part feels, whatever it may be, like, I have no reason to not believe you. And I don't have anything to be like, whatever, you can tough through it, So I think there is actually, in my opinion, at least more empathy for those patients, because I see someone suffering in front of me in whatever way that is. And like, that's their experience. I don't get anything to judge with that. I've also used, kind of sometimes the arguments, hey, I have, like, you don't have to go to someone, you don't have to, your oncologist doesn't have to have had cancer, or your, cardiologist doesn't have to have heart disease for you to go and respect them. And I, it's interesting. So I have 3 daughters and a son, and my eldest daughter actually sitting at dinner tonight. And, I don't know how it came up, but she was like, when I tell my male friends, what you do, they're like, oh, sweet, he gets to look at vaginas all day.
Oh my gosh.
And it's like, so obviously when people come to the doctor, typically, I mean, yes, we do have our well patients that we see for just annual exams, but usually there's a problem. And it's someone, there's like a vulnerability with that has to be respected. And you have to, in my mind, do everything possible to make sure that person feels safe, and they have agency about things, and that they really feel that they're kind of in control of the exam. I think that's what we do really well. We do trauma-informed care for all of our patients that see us. And so that's my thing. Yeah,
and you explain it, that analogy with, like, your oncologist doesn't need to, like, have experience with cancer. That is very accurate. And also, there is many females out there who actually say they prefer a male gynecologist because they are more gentle. They actually, you're right. They don't know exactly what you are feeling. So they are going to be more gentle and charismatic with you, according to other individuals, not to diss on any female gynecologists.
Sure, of course.
But females sometimes prefer, just like sometimes females prefer male counselors, things like that. They're just more gentle and according to other people, more understanding. So I really loved your response on that. Thank you so much for answering that. Moving on to the last segment here, the question and answer session I like to call Taboo Talks, questions to communicate. That's my little saying.
I love that.
Thank you. So I'm going to ask you a couple of questions, and I want you to make or break the myth. Okay?
Okay.
Okay. Is it true you lose your labia majora at menopause?
So that's okay. So what happens with menopause? As ovarian hormone levels are going down lower and lower and lower, you can develop a condition called genitourinary syndrome of menopause. And one of the things that happens with that is that there is a change in what we call tissue architecture. So the labia, both majora and minora, can kind of flatten and shrink in. And so you're right, you can, if you don't do anything about that. But vaginal estrogens are very, 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 very safe, and were actually recommended for almost every menopausal woman, because they reduce mortality from urinary tract infections and vaginal infections, and they reverse that and keep that from happening.
Wow. Okay. I thought that was going to be a myth. All right. Is it true that you are not supposed to have sex at least 10 days after a pap smear?
No, I know there's no really, I mean, trying to think, like, why would there be, like, I mean, that's a specific time, but especially after a pap smear, no, I don't see any reason why. I mean, you could have pap smear that, or have sex that day if you wanted. It's not going to hurt anything.
So the
So,
myth is that after a pap smear, so people believe that a pap smear, instead of it being like a little scrape, it's a cut. And well, it kind of is a cut.
ah,
But they're scraping the cells, and that if
sure.
he ejaculates inside of you, the next time you get a pap smear, it's going to be irregular cells within those
Mm.
findings, and you're going to have to go get checked. So what do you think about that one?
So I can see kind of where that's coming from, no pun intended. But so the cervix, actually, the cells on the cervix turn over fairly rapidly.
Okay.
So even if you were to, so let's say you have a raw cervix, and when you do a pap smear, you're basically kind of brushing off that outer cell layer, and yeah, you get a little bit on the what's called a endocervix as well to get some of those cells. But it should never, you should never be cut. I hope no one ever cut, especially on a pap smear. If you had a
People
biopsy,
think
that's
that.
maybe a little bit of a different story. But even if, I mean, you know, if you put a whole bunch of semen against it, first of all, the sperm's going to die, like,
Yeah.
in its time life. But the natural cervical discharge can kind of wash some of that stuff out, and those cells are going to turn over very rapidly, within usually about a week or so. So it's not going to leave any type of permanent stuff. Now, if you had HPV
Hmm.
and had that kind of going on, that's typically what causes like 99% of abnormal pap smears, that end up being something more than just kind of, what's called ascus, or where the cells kind of had a bad day.
Okay. All right. So I would say that that one is a myth.
I'd say it's a myth.
It's a myth. Okay. Is it true you only need to go to the gynecologist if you've had sex or are having issues?
So I would say that's kind of a partial myth.
Okay.
I mean, well, I would say no. That's probably like So some people, we recommend that people go and have an annual what's called well woman exam. Once you
Yeah.
start at age 21, whether you're sexually active or not, we still recommend you would go in and get seen. Now, a gynecologist can do those, but so can a family doctor, an internist, or things like that. So that's where that kind of like weaseling comes in. But I do recommend that anyone, regardless of age, gender, or whatever, has an annual physical.
Yes.
Now, a pap smear screening for cervical cancer from ages 21 to 65 only needs to be done every 3 to 5 years,
Okay.
depending on
Not
kind
know
of,
that.
yeah, what your health issues are, or things like that. So you can go to the GYN and have a well woman exam and not have a pap smear.
Hmm.
Yeah, so it's not like it's a prerequisite of it. That's a specific screening test just for cervical cancer.
I get a pap smear every year now, since I turned 21, That's before, I mean, I went to the gynecologist for the first time when I think like 15,
Sure.
15, and then my mom wanted me to like get checked because I happened to lose my virginity. And so then I obviously didn't get a pap smear until 21, but where I go, they have me now do a pap smear every single year.
So, and this is something that we sometimes have patients say, "Hey, I get PAPs every year," and what they're getting is a speculum exam.
Mm,
Now, the PAP itself is actually that scraping. So, if your doctor or healthcare provider does that every year, it's not that there's anything wrong with that per se. It's just not
okay.
the kind of current guidelines. And the reason is because cervical cancer, which is what we're testing for, is very, very slow growing. On
Okay.
average, it takes a decade from someone to have an abnormal pap to develop into cervical cancer if you don't do anything. So, like I said,
Okay.
and testing for STIs, that can be done obviously every year. They still
Yes.
recommend like, full physical every year, things like that. But as far as the actual PAP test itself, the current guidelines, like I said, say 3 to 5 years, depending on things. So,
Okay.
yeah.
Next one. Is it true that sperms swim if he ejaculates on her thigh?
So sperm are going to swim as sperm do, but they are not going to be able to get all the way, up there, with any degree of frequency.
Okay.
Yeah, I mean, obviously there are weird things that happen all the time. I don't want to say it's 100% impossible, but you would have to have ejaculation on the thigh, then she'd have to, like scoop it into the vagina and like
Right.
turn upside down, something like that. So the
Okay.
general like pulling out, you know, typically pregnancy occurs with that kind of withdrawal method because there may have been some sperm in either pre-ejaculate or maybe, a shot got off before you're able to fully pull out or things like that.
All right. Interesting. That's actually a huge one. And the next one, there's two more. The next one
Okay.
is it true that you can't get pregnant on your period?
So for most people, that is going to be true.
Okay.
Now, the issue is going to be, so ovulation can occur if you have an average menstrual cycle. So the start
Mm-hmm.
of the first day of one period, the start of the next day is going to be, textbook 28 days. Ovulation is going to occur around day 14. Um, so sperm can live up to 7 days in the most like specific circumstances. So in theory, like if you were to be on the seventh day of your period and then have sex, and then, that sperm were to last for 7 days, and then you have that ovulation, then there's a slight chance there. But what we sometimes will
Oh.
see is the first time of the menstrual cycle before ovulation is called the follicular phase, and that can sometimes be really short. So if your period only lasts, let's say, 3 days,
Mm-hmm.
and you ovulate on day 8 or day 10, in theory, that could happen. So
Okay.
that's kind of the, like, once again, the little asterisks. Like, for most people, no, you can be fairly safe with, internal ejaculation when you're on your period and not really have to worry about it. But if your periods are really irregular when they occur, I would probably not use that as really your best form of contraception.
Okay. Last one. And this one is a silly goose one, but it was asked.
Sure.
Is it true that you can tell that your partner is cheating based on your pH balance being off? Like there's changes in their discharge?
Sure. That would not be a good test for infidelity.
Yes.
Yeah.
Yeah, that's exactly. I responded the same way. There's just so much going on in the vaginal flora,
Hmm.
especially if it's a new partner or if you're a
Right.
partner, especially if they came in you and your partner ate too much McDonald's that week. Um,
Sure.
there's just so many things going on. So
Yeah.
thank you for making or breaking those myths.
Sure. Of course.
The last thing, I want to know where to find you. What's your sneaky links? How can I find you?
Yeah. So our website for our kind of clinic is havencenter.com. I'm at Dr. Corey Babb on Facebook, and then Dr. Corey Babb on Insta and TikTok. And those are
Awesome.
probably the best places to find me.
And if there is one thing you could say to an individual going through anything, whether it be relationship, sexual dysfunction, female or male, what would you say?
I would say no, that you are most likely not alone with this. And there are things that we can do to help you get to where you want to be, whether that's sexually, hormonally, or anything beyond.
Okay. Thank you so much for coming on. I really
Yeah, my
appreciate it.
pleasure.
So that's all, folks. That was Talking About the Taboo with gynecologist Dr. Corey Babb. If you liked what you hear, please like, subscribe, and follow this podcast on YouTube, Spotify, and Apple Music. Dr. Corey Babb really wanted me to discuss the fact that he refers to himself as the sexual Dr. Rogers, the medical Dr. Rogers. Loved that. He is also releasing a book, Practical Guide to Female Sexual Medicine. It is up for pre-order in April. It'll be at Barnes & Noble and Amazon and other apps as well. Thank you so much for listening to Talking About the Taboo with Natalie Malloy. And always remember to communicate.